Welcome to Deep Dive Ortho, where we skip the fluff and get straight to the insights you truly need to master your practice. Today, we're taking a plunge into something incredibly common yet profoundly impactful: hand arthritis. It's easy to overlook just how much we rely on our hands, isn't it? From the simplest tasks like turning a key to the most intricate work, our hands are central. So when pain sets in, it doesn't just hurt, it reshapes a patient's entire world. Did you know musculoskeletal conditions affect a staggering 18 million people in the UK alone? Many experiencing pain daily for years, decades even. That's nearly 3 in every 10 people struggling with constant discomfort, and a disproportionate number grapple with hand arthritis. Our mission for you today is a deep dive into the nuanced clinical assessment and cutting-edge management strategies. Think of it as your shortcut to confidently diagnosing these conditions and delivering truly patient-centered care. And guiding us through these complexities, we're honored to welcome Professor Mo Imam, a distinguished expert in orthopedic conditions. Professor, thank you for joining us.
Thank you. It's a privilege to be here. And you're right, it touches so many lives and really impacts a patient's independence.
Indeed. Let's begin at the very foundation, Professor. Could you walk us through the fundamental process of arthritis, specifically in the hand?
Absolutely. At its core, arthritis is a disease attacking joint tissues.
The joint tissues themselves.
Exactly. A joint is simply where two bones meet. The attack might target the joint lining, the synovium, or that smooth protective cartilage covering the bone ends. Eventually, this cartilage breaks down. It wears away.
Leaving the bones exposed.
Precisely. And when that protective layer is gone, the exposed bones start rubbing directly against each other. That friction leads to wear, damage, inflammation, and significant pain. Our hands are marvels, really. 27 small bones, numerous joints in each hand built for precision and power. Given that sheer number of small, frequently used joints, well, it's perhaps no surprise the hand is such a common site for arthritis.
So with so many joints, which specific areas are the most common culprits, the hot spots, if you will?
We typically see it affecting four main areas. First, the base of the thumb, where the thumb meets the wrist. That's the carpometacarpal joint, or CMC joint.
Right, the CMC. Very common.
Very. Then, the knuckles, or the metacarpophalangeal joints, the MCPs. After that, the middle joints of the fingers, the proximal interphalangeal, or PIP joints. And finally, the top joints, nearest the nails, the distal interphalangeal, or DIP joints. Those four are where you'll most often find it.
You mentioned the profound impact on daily life. It's easy to intellectualize pain, but tasks like turning a key really hit home. In your experience, what's a surprising way this progression manifests?
That's an excellent point. The impact is profound and often deeply frustrating. As it progresses, it doesn't just cause pain, it steals independence. Think about fastening buttons, turning a door handle, gripping a cup, holding a pen.
Things we take for granted.
Exactly. They become incredibly difficult, painful, sometimes impossible. What might be surprising is the emotional toll. It's not just physical pain. It's loss of self-sufficiency, inability to engage with hobbies, maybe difficulty with personal care. That functional decline is absolutely critical to assess. It dictates so much of our management strategy.
That makes perfect sense. Now, let's delve into the different types. They each have distinctive features, don't they? Let's start with osteoarthritis, OA, the one many patients know as wear and tear.
Yes, OA is the most common form. Wear and tear is a common term, but it's really a degenerative process. The main mechanism is that gradual breakdown of cartilage, that smooth cushion on the bone ends. Without it, bones rub directly. That leads to the pain, the stiffness, the loss of movement over time.
And are there characteristic features we should look for?
Definitely. Clinicians should look for those characteristic bony lumps or nodules. On the middle finger joints, they're Bouchard's nodes. And on the top finger joints, closer to the nails, they're called Heberden's nodes. Very telling signs of established OA.
And where does this OA typically show up in the hand?
It most commonly impacts the wrist, specifically that base of thumb joint, the CMC joint we mentioned, and importantly, the middle and top joints of the fingers, the PIPs and DIPs. That distribution is quite distinct.
So if OA is the wear and tear story, rheumatoid arthritis, RA, it's fundamentally different. The body as the antagonist, how does that unfold?
You've hit the core difference. RA is a chronic inflammatory autoimmune disease. The body's own immune system mistakenly attacks healthy joint tissue.
Primarily the synovium.
Primarily the synovium, yes, the joint lining. Initially it swells, produces excess fluid. But this isn't benign inflammation. Persistent inflammation basically turns the body's own immune cells, like neutrophils, into, well, tiny demolition teams. They get into the synovial fluid, produce destructive proteases, reactive oxygen species, highly damaging to cartilage. Couple that with this diffuse synovial hypertrophy, the lining gets overgrown, thick, and you end up with laxity in the capsule and ligaments.
That sounds incredibly destructive. What's the most profound clinical consequence you see from that regarding joint deformation?
Precisely. That laxity allows tendons and ligaments to weaken and stretch. The joints lose their natural shape, their alignment. A classic example is ulnar deviation at the MCP joints. The fingers drift dramatically towards the little finger side.
Quite a striking visual.
It is. You might also see the finger bone shift forward on the knuckle-volar subluxation. It massively compromises function. These deformities aren't just cosmetic, they represent a fundamental loss of hand mechanics.
Is there a distinctive pattern of RA involvement? Is it typically symmetrical?
Yes, that's a key feature, a crucial diagnostic clue. RA commonly affects the small joints of the wrists, hands, fingers, and typically does so symmetrically. If one hand is affected, the other is highly likely to be as well. That symmetry helps differentiate it.
Next, psoriatic arthritis, PSA, the skin joint connection. How does that present differently?
Psoriatic arthritis affects both the skin psoriasis, those red scaly patches, and the joints. Patients often get joint pain, morning stiffness, but also that distinctive swelling of an entire finger or toe, dactylitis, the sausage digit.
Ah, dactylitis.
Yes. Well, it shares features with RA. A key difference is PSA might only involve several fingers, and crucially, often asymmetrically. Unlike the typical RA symmetry, you might also see specific nail changes pitting or onycholysis, the nail lifting off. Telltale signs.
Beyond these main types, Professor, are there other less common but important forms we should keep in mind?
Yes, vital to have these on the radar because management differs. Gout, for instance, monosodium urate crystals. The hallmark is that acute, sudden, excruciating attack, often middle of the night, intensely painful within hours. Usually one joint, often the foot, but can hit the hand.
And pseudogout.
Calcium pyrophosphate crystals. Can mimic gout, but often affects larger joints like the wrist, maybe less intense. Then you have systemic conditions like systemic lupus erythematosus, SLE, and other autoimmune disease, and hemochromatosis, excess iron deposition causing joint issues. Less common, yes, but recognizing them needs specific tests and is critical for the right management.
Fascinating how many pathways lead to arthritis. Now, who is more likely to develop it? Are there specific predisposing factors?
Yes, several factors increase the likelihood. Age is significant. OA, commonly after 50, often cumulative stress. RA typically appears earlier, maybe 35 to 50.
Demographics.
Women are more susceptible than men to many forms. White individuals also tend to show higher prevalence. Lifestyle plays a role. Obesity increases mechanical stress, makes you more prone to OA. And critically, previous hand injuries, dislocations, fractures are a big risk factor for post-traumatic arthritis. The initial trauma disrupts things.
And genetics.
Yes, there's definitely genetic predisposition. Inherited genes influence development and severity that often runs in families.
That's a brilliant overview of the core concept. So with that foundation, the critical next step is recognition and diagnosis. How do we spot these conditions when a patient presents? Let's talk clinical presentation, early warning signs.
Excellent question. The patient's story is often the first, most crucial tool. Early symptoms, usually a dull or burning joint pain. Patients might notice it hours or a day after increased hand use. They'll also report morning pain and stiffness, often accompanied by visibly swollen joints.
And how do these symptoms typically progress?
As arthritis advances, symptoms become more frequent, often more severe. The pain might sharpen from a dull ache to something intense, persistent, sometimes waking patients at night. They might instinctively change how they use their hands, developing compensation patterns. The surrounding tissue can become red, tender, indicating active inflammation.
And that grating sound.
Ah, yes. Crepitus, that grating, grinding, cracking, or clicking when bending fingers. Very characteristic. Patients might also notice they can't fully open or close their fingers anymore.
What about visible deformities? Specific changes to look for?
Absolutely. Over time, distinct deformities become obvious. In OA, you'll see those hard, bony nodules. Bouchards on the middle joints, Heberdins on the top joints. Finger joints can look enlarged, deformed, sometimes abnormally bent. This contributes to weakness, reduced function.
And for RA?
For RA specifically, look for that dramatic ulnar deviation fingers drifting significantly towards the little finger. Also, classic RA deformities like swan neck PIP hyperextends, DIP flexes, and boutonniere PIP flexes, DIP hyperextends, like a buttonhole. These indicate significant joint and soft tissue damage, crucial for diagnosis.
You've repeatedly highlighted the functional impact, particularly around the MCP joints. Just how critical are they?
The MCP joint, the knuckle, is absolutely critical. It contributes a huge chunk, around 77% of the total finger flexion arc, vital for both gross gripping and fine precision pinching.
So when arthritis hits the MCPs,
Especially thumb and index finger MCPs, due to pinch stress, patients get substantial pain and disability. Struggling to hold objects, weak hands, difficulty turning a key, opening jars, undoing buttons, picking up small things. Understanding this specific functional impact is paramount. It often drives the patient to seek help and really informs our treatment goals.
so we start with the patient's narrative, meticulously extracting their history. Now, the clinical assessment. How do we begin differentiating joint versus soft tissue symptoms?
A fundamental first step. Is the pain truly intra-articular inside the joint or from extra-articular structures like tendons, muscles, ligaments, nerves? History gives clues. Is pain worsened by specific joint loading or muscle contraction? Sometimes pain is felt in the hand but starting elsewhere.
Like nerve compression higher up.
Exactly. Or even conditions like fibromyalgia causing widespread pain but a normal joint exam. The character of pain, its relation to movement or rest, helps differentiate early on.
And establishing chronicity, acute versus chronic.
We generally define chronic as symptoms lasting over 6 weeks. Was the onset sudden, dramatic, or gradual, associated with trauma, infection? How did it respond to previous treatments? Think of gout, very acute, sudden attacks, responds well to NSAIDs. Contrast that with RA, typically more insidious, variable course remissions, exacerbations. A very different picture.
This distinction between inflammatory and non-inflammatory seems incredibly important. Can you elaborate on the key features, almost a checklist?
Absolutely. It's a cornerstone. Inflammatory conditions like RA, PSA typically have prolonged early morning stiffness, often over 30 minutes. And critically, it eases with activity.
Eases with activity, that's key.
Very specific. Pain is often present at rest, varies unpredictably. Swelling might be intermittent, but often warm, visibly swollen, tender. And crucially, inflammatory conditions often have systemic symptoms: fever, malaise, weight loss, night sweats, indicates a broader process.
And non-inflammatory, like OA.
Conversely, non-inflammatory pain, like an OA, is more related to use. Worsens with activity, relieved by rest. Stiffness is usually localized, short-lasting under 30 minutes, tends to recur after inactivity like sitting. Swelling, if present like in nodal OA, is often bony, hard, non-tender, and systemic symptoms are typically absent. It's localized.
What about the pattern of joint involvement? How does that help narrow things down?
Incredibly helpful. We classify by number of affected joints: monoarticular, 1; posterticular, ligaroarticular, few; 2, 4; polyarticular, many, 5+. Then symmetry versus asymmetry. RA is typically a symmetrical polyarthritis, same joints, both sides, often small joints of hands, feet. If it hits one MCP, often hits them all. Contrast that with, say, psoriatic arthritis, more likely asymmetrical, scattered pattern. OA affects specific joints, base of thumb, PIPs, DIPs, often somewhat symmetrical, but not overtly inflammatory.
Beyond clinical signs, understanding the functional impact is paramount. How do we effectively gauge this? Moving beyond just pain scores.
Indeed crucial. Truly patient-centered. Go beyond, does it hurt? Ask open-ended questions about function, specific difficulties. Ask them to describe a typical day. Getting out of bed, washing, dressing, preparing food, personal hygiene gives real-world context.
Exploring impact on work, leisure.
Absolutely. Potentially sensitive areas. Impact on employment, ability to do their job, hobbies they enjoyed. The WHO ICF model is a good framework. Links impairment, like lost motion, to activity limitation, difficulty with buttons, to participation restriction, can't play piano or work. It's about understanding their needs, aspirations, concerns, expectations for recovery.
And involvement of other systems or comorbidities. Is inflammatory arthritis just a joint issue?
No, inflammatory arthritis often involves other systems, unlike localized OA. Patients might report skin, eye, lung, kidney symptoms. Depends on the specific condition. Also, general symptoms: malaise, weight loss, mild fevers, night sweats. Chronic fatigue, depression are common too, with chronic pain or functional loss. Vital to screen for these systemic symptoms, and essential to consider comorbidities, especially in older patients. They significantly affect treatment choices. Liver disease might limit certain DRNs, for example.
Now, the physical examination. Bringing the clues together. Can you introduce the GLS screen and then the more detailed REMS exam?
Of course. GLS, gait, arms, legs, spine. is a rapid, maybe 1 or 2 minute screen for significant musculoskeletal issues. Starts with 3 simple questions. Any pain, swelling, stiffness in muscles, joints, and back? What? Can you dress yourself completely without difficulty? What, can you walk up and down stairs without difficulty? A no to all makes significant disorder unlikely. You can generally rule it out.
And the brief examination itself.
Observe gait symmetry, smoothness, turning. Observe posture from behind, side, front, muscle, bulk, alignment, full elbow-knee extension, foot abnormalities. For arms, hands behind head, shoulder elbow movement, straighten arms fully. Inspect backs of hands, swelling deformity, then palms, muscle bulk. Assess power grip, make fist, squeeze fingers. Fine pinch, each finger to thumb. And crucially, gently squeeze across the MCP joints for tenderness, very sensitive for inflammation.
And when GLS flags an issue, REMIS provides the detailed assessment.
Precisely. REMA is regional examination of the musculoskeletal system. It's the more detailed exam when abnormality is detected. Structured using look, feel, move, function. Look is systematic visual inspection. Compare sides. Skin changes, muscle bulk, wasting, swelling, deformity, alignment. Feel involves assessing skin temperature back of your hand, characterizing swelling soft, fluctuant fluid, or hard, bony osteophyte. Eliciting tenderness by careful palpation. A key sign for inflammatory joint disease is the synovitis triad, that distinct warmth, swelling, and tenderness on palpation.
Warmth, swelling, tenderness, got it, and move.
Assessing both active and passive range of motion. Active is what the patient does. Passive is what you can achieve moving the joint for them. A big difference, active limited, passive okay, often points to muscle, tendon, or nerve issues, not the joint itself. We also assess hypermobility, and the end feel that sensation at the limit of passive motion. Reveals a lot, firm, bouncy, empty. Function is direct assessment, reaching mouth with hand, observing gait. And experienced practitioners might use special tests too.
That's very practical. Could you give specifics for applying REMS to the complex hand and wrists?
Certainly. For hand-wrist, look. Palms down posture, swelling, deformity like ulnar deviation, wasting, scars. Check skin thinning, bruising, rashes. Nail psoriatic pitting, onycholysis. Note symmetry, small joints versus wrists. Palms of the Nahipothenar wasting. Palmar erythema, carpal tunnel scar. Check elbows too, nodules, plaques.
And for feel?
Palpate peripheral pulses. Feel for tendon thickening. Assess the Nahipothenar bulk. Test sensation median, ulnar, radial distributions. Light touch. Assess skin temperature back of hand across forearm, wrist, MCPs. Compare sides. Critically, gently squeeze across MCPs for tenderness. Performed by manual palpation of swollen painful joints, MCP, PIP, DIP, wrists. Check for active synovitis warmth, swelling, boggy texture, effusions. Feel for bony swellings, Heberdin's node, squaring of CMC thumb in OA.
Then move.
Ask patient to fully straighten fingers, then make a fist. Note difficulty, pain. If active is limited, passively move fingers, differentiate joint versus tendon rupture versus nerve issue. Assess active passive wrist flexion extension, the Player sign, and reverse prayer sign. Can do Phelan's test for carpal tunnel force flexion for 60 seconds, reproducing symptoms. Assess power, median, ulnar nerve muscles, thumb abduction, finger spread.
And finally, function.
Ask patient to grip your fingers, power grip. Pinch your finger, pinch your grip. Pick up small objects, undo buttons, fine motor skills. All vital for daily activities, shows functional limits.
An incredibly thorough guide to the hand exam. Beyond clinical assessment, what investigations help confirm suspicions?
After a history and exam, plain x-rays are usually the most useful initial step. They show characteristic changes, cartilage loss, bone spurs in OA, erosions in RA. They also provide a historical record, as changes are gradual. We use classifications like Eaton and Littler for CMC Joint Arthritis, Kellgren and Lawrence for finger OA to grade severity and guide treatment.
Are more advanced imaging techniques useful? When would you use them?
Yes, definitely. Ultrasound is increasingly used. Good for identifying early inflammation, visualizing synovial thickening, though clinical signs might already suggest this. Great for dynamic assessment. CT is superb for detecting early arthritis, assessing bone quality, subchondral cysts, crucial for surgical planning, especially with osteopenia or erosive changes. MRI plays a minor role in primary diagnosis, but advances allow detailed visualization of cartilage, synovium, useful for detecting very early inflammatory stages, soft tissue changes, planning complex surgery like osteotomies.
And blood tests. What specific markers are we looking for? Nuances in interpretation.
Invaluable, especially for inflammation. Inflammatory markers like ESR and CRP. CRP responds faster within days, giving a more immediate picture of disease activity.
What about autoantibodies?
For rheumatoid factor and anti-CCP antibodies are often strongly positive, a definitive marker. But rheumatoid factor can be nonspecific, positive in healthy elderly or other conditions, interpreting context. For gout, Check serum uric acid, though crucially, levels can be unreliable during an acute attack, sometimes normal. Specific markers exist for SLE, hemochromatosis, and critically, for acute monoarthritis with systemic symptoms, blood cultures are essential to rule out joint infection, a surgical emergency.
Finally, synovial fluid analysis. When and why? What does it tell us?
Vital, especially if infection is suspected. Acute monoarthritis, systemic symptoms, rapid progression. Send fluid immediately for culture. Gram stain to identify the bug. Also, if gout or pseudogout suspected, examine under polarizing microscope for crystals. Needle-shaped, negatively birefringent for gout, monosodium urate. Rhomboid, weakly positive for pseudogout, calcium pyrophosphate. This analysis can definitively confirm or exclude crystal arthropathies. Fundamentally changes diagnosis and management.
Okay, Professor, we've navigated diagnosis, history, exam, investigations. Now let's explore treatment options in segment 3. What's the initial approach for early primary arthritis?
The initial approach is conservative, multimodal, a combination of non-surgical interventions aiming to preserve function, alleviate pain, slow progression without immediate surgery. Foundational step often sees significant improvement.
Let's start with splinting and braces. Their purpose. How are patients guided?
Splints serve multiple purposes: support, protection, reducing deformity, joint stability, limiting unwanted movement, lessening strain, promoting alignment. Healthcare providers, OTs, hand therapists guide patients on options, how and when to wear them for how long. Crucial education. Wearing them too much can cause weakness, stiffness. It's a balance. Thumb CMC resting splints can be effective, less limiting. Intrinsic plus splinting with exercises can improve motion, strength, pain, dexterity.
And hand therapy exercises, how important are they both conservatively and post-surgery?
Incredibly important, arguably indispensable. A hand therapist designs specific strengthening, stretching exercises, reduces symptoms, improves mobility, enhances function. Post-surgery, or conservatively, emphasis is on regular, frequent home exercises, often every 2 hours daily, regains maximum movement, function, prevents stiffness, atrophy.
Any specific tips for exercises?
Yes, a helpful functional tip, especially for the thumb, is to keep the thumb tip bent during movement. Ensures you engage intrinsic thumb muscles, not just compensate with stronger extrinsic extensors, more therapeutic effect.
What about broader lifestyle modifications? Practical advice.
Significant, often underestimated. Simple things. Hot-cold packs. Cold for acute pain swelling, heat for stiffness at ease. Regular rest periods are vital. Healthy eating, managing systemic conditions like diabetes, cholesterol. Crucially, weight management if overweight obese reduces joint stress, inflammatory burden, and smoking cessation. Strongly advised. Smoking increases systemic inflammation, worsens arthritis risk. OTs can teach use of self-help devices, jar openers, specialized cutlery, adapt routines, maintain independence.
Let's move on to pharmacological management. Tailoring meds for different types.
For osteoarthritis, focus is mainly symptom management. No meds currently approved to slow structural progression definitively. Options: analgesics like acetaminophen for pain, NSAIDs for pain and swelling, ibuprofen, diclofenac, naproxen, celecoxib.
Topical options.
Yes, topical NSAIDs applied directly over the joint are often first choice for hand OA. Limited systemic absorption, fewer renal side effects than oral NSAIDs.
And for inflammatory types like RA and PSA, mainstay treatment.
For APSA, disease-modifying anti-rheumatic drugs, DMARDs, are the cornerstone. Not just symptom relief, but crucially, slowing underlying disease progression, preventing irreversible damage. Examples: conventional synthetics like methotrexate, hydroxychloroquine, sulfasalazine, leflunomide, they suppress immune overactivity.
Co-managed with rheumatology.
Yes, often co-managed. A crucial multidisciplinary approach. Perioperatively, some conventional DMARDs like methotrexate might continue. Biologics are typically stopped, surgery timed at end of dosing cycle to minimize infection healing risks.
What role do corticosteroids play? Critical considerations.
Corticosteroids offer rapid, potent anti-inflammatory and analgesic benefits. Oral, IM, IV, or commonly direct joint injection, often used as bridge therapy for rapid relief until DMARDs work, but effects wane over 6-12 weeks. Long-term systemic use has significant side effects. Critically important to consider comorbidities, diabetes, cardiovascular disease, osteoporosis. Can hinder or preclude steroid use due to adverse effects like raising blood sugar, fluid retention, bone thinning. Used judiciously.
And the more potent immunosuppressives and biologics.
Immunosuppressives like azathioprine, cyclosporine, and biologics like adalimumab, etanercept, and infliximab play a vital role. Slow disease progression, significantly reduce joint damage in RA, often achieving remission. Typically for more severe cases or when conventional DMARDs fail, Research continues yielding newer targeted meds for PSA, RA. Ongoing studies expand our arsenal, also encouraging early findings from stem cell research for OA, though still experimental.
What about supplements like glucosamine and chondroitin? Are they helpful?
Important clarification. These aren't reviewed or approved like medications. Don't undergo the same rigorous trials. Some trials report minor pain relief for some, but no conclusive high-quality evidence they slow OA progression or repair cartilage. Evidence remains mixed, really. Patients should always consult their provider before taking supplements, potential interactions with meds, or side effects themselves.
Beyond oral meds, injections offer targeted relief. How do steroid injections work? Limitations.
Steroid injections deliver potent anti-inflammatory meds directly into the joint, targeted pain relief, reduce local inflammation, used when oral is insufficient, or inflammation limited to few joints. Rapid, localized effect. However, a crucial point, repeated injections are limited. Steroids can weaken tendons, ligaments over time. Risk of rupture, instability, so typically only a few times per joint. Careful consideration of interval between injections, avoid cumulative damage.
And hyaluronic acid injections, particularly for CMC1, the evidence seems mixed. Bottom line.
Precisely. Evidence for HA, especially for CMC1, is nuanced, frankly questionable long-term efficacy. Some early findings reported short-term pain relief, better pinch strength, but other well-conducted trials found no significant long-term difference versus placebo or steroids in pain or strength. Some studies showed relief at 6 weeks, gone by 24. Comparisons with cortisone showed cortisone reduced pain at 12 months, HA did not. No significant overall difference. Inclusion. Long-term therapeutic value remains debatable. Need to be clear about questionable long-term efficacy when counseling patients.
A vital distinction. Any emerging injection therapies worth mentioning?
Briefly, yes. Pilot studies on intra-articular infliximab, a biologic for interphalangeal joint arthritis, showed significant pain reduction, but notably, no significant grip strength improvement. Highlights ongoing search, but also complexities of functional improvement.
So, Professor, when conservative treatments fail or disease progresses severely, surgery becomes an option. General indications. Factors guiding choice.
Surgery is considered when non-surgical options consistently fail to give adequate pain relief, or cartilage is significantly worn away, causing severe symptoms, functional impairment impacting quality of life. Choice of approach is highly individualized. Depends on type stage of arthritis, number location of joints, patient age activity level, dominant hand involvement, comorbidities, overarching goal, decrease pain, improve mobility function, enhance quality of life, independence.
Let's delve into primary approaches. Joint fusion, arthrodesis. What does it entail? Trade-offs.
Arthrodesis stabilizes bones using internal fixation plates, screws, fusing them into one solid bone. Primary benefit: stable, strong, pain-free joint. No more movement causing friction. Inherent trade-off: permanent loss of flexibility, movement in that specific joint. Chosen when stability pain relief prioritized over motion.
Which hand joints are typically fused? Expected outcomes.
Proven, reliable for several hand joints. Thumb MCP joint frequently used. Tension band fixation is cost-effective. Fusion rates high, 83 to 100% with K-wires. Optimal angle 20-25 degrees flexion. Slight pronation for pinch grip. Finger DIP joint, very tip joint, commonly used, reliable. Excellent consolidation, high patient satisfaction. Full motion isn't critical there. Thumb IP joint within the thumb. Reliable with double-threaded screws. Provides stable, pain-free platform.
Then joint replacement, arthroplasty. Artificial implants. How does this differ, especially for finger MCP's advancements?
Arthroplasty removes damaged surfaces, replaces with artificial implants, plastic, ceramic, silicone, metals. For finger MCPs, generally preferred over fusion to preserve motion crucial for hand function. Gold standard historically was silicone implant arthroplasty. Reliably improves pain motion. Long-term survival, 63-97%. Modern options: pyrocarbon metal plastic surface replacement, SRA. Try to mimic native anatomy better, but paradoxically can have higher complication rates than silicone. In RA patients, metal plastic SRA shows notable improvement in pain, grip strength, range of motion. Impressive survivorship, 95% at 10 years, 85% at 20 years. Demonstrates long-term efficacy.
What about arthroplasty for thumb MCP and PIP joints? As common or successful?
Thumb MCP arthroplasty, less common than fusion. Can be indicated for motion preservation, especially if IP or CMC motion already limited. Preserving MCP motion might be functionally beneficial then. For PIP joints, wide range of prostheses. Can be effective for function pain, but tend to have higher complication rate than MCP silicone arthroplasty. Modern PIP prostheses are more expensive but offer greater stability. Better suited for index middle fingers, where precise pinch grip more critical.
Any other surgical procedures beyond fusion and replacement?
Yes, certainly. Tendon transfer is sometimes used if inflammation caused tendon rupture, loss of movement. Transfer a portion of healthy tendon to restore function. Also, synovectomy, surgical removal of inflamed synovial tissue, often combined with realigning extensor tendons, specifically for inflammatory arthritis. Reduces inflammatory burden, helps maintain alignment, especially before significant joint destruction.
After surgery, managing recovery is crucial for outcomes. What should patients expect immediately post-op and long-term rehab?
Immediately post-op, hand protected with cast or splint for healing. Then transitions to intensive, structured rehab with a hand therapist, typically referred to specialist unit. Attend sessions minimum once or twice weekly for first 6 weeks. Tailored frequency after based on progress. Intensive rehab under expert guidance, absolutely critical for regaining movement, strength, function.
What about the splinting regimen?
Usually 2 splints, one worn overnight for rest protection, typically on constantly for first 5-6 weeks. Second for day use, allows some controlled movement and exercises. Regular, frequent home exercises, often every 2 hours, daily paramount to maximize movement, prevent stiffness, requires significant patient adherence, motivation.
And wound care. Progression back to daily activities. Practical advice.
Wound care involves regular review, redressing by therapy team. Stitches usually out 10-14 days post-op, depending on healing. Functional progression. Avoid heavy use for first 6 weeks. Allow tissue healing. After that, gradually increase use under therapist guidance, usually up to 12 weeks. By then, sufficient healing allows most tasks safely. Practical guidance given pump dispensers for hygiene, adaptive equipment, fosters early independence.
And the big questions. Returning to driving and work.
Very practical concerns. Impact independence, livelihood, generally advised not to drive for first few months, can return when comfortably make tight fists without pain, and critically, can safely perform emergency stop without hesitation or discomfort. Ensure safety. Return to work timeline varies significantly, usually off work few months. Depends on job nature manual versus desk-based and dominant hand surgery. Some return sooner for light duties with splint, task modification.
Professor, we've covered a tremendous amount. Understanding types, diagnosis, treatment spectrum. Let's move to segment 4, navigating challenges and future directions. Potential complications. Surgical and non-surgical.
Crucial for realistic understanding. Surgical. General risks include lack of expected improvement, disheartening. Infection, though rare, 0.1%, often Staph aureus, is serious. Managed with antibiotics, maybe debridement. Long-term, implants might need replacing if break or wear out.
Specific complications for fusion or replacement.
Fusion-specific non-union bones fail to grow together. Or malalignment. Thumb MCP non-union 9%. Risks. Smoking, diabetes impair healing. Arthroplasty-specific. Implant loosening, rotation, fracture, especially older silicone, 2%. Implant instability up to 31% for SRA, 19% pyrocarbon. Pyrocarbon has highest acute dislocation rate. Other issues. Metacarpal head fracture, screw cutout with some fixations, can compromise outcome.
And non-surgical risks.
Long-term systemic NSAIs carry significant risks. Renal, GI pathology, kidney damage, ulcers, DRRs, while essential, suppress immune system. Increase infection risk, can delay wound healing perioperatively, why we often adjust regimen before surgery.
What's on the horizon? Current research, future outlook.
For OA, encouraging ongoing clinical research on stem cell treatment. Early findings promising. Aim to regenerate cartilage, reduce inflammation, potentially alter disease course, though still largely investigational. For inflammatory arthritis, past decades saw truly significant development of new meds biologics, targeted synthetics for PSA, RA, many more studies underway. Immense hope for better disease control, outcomes, even sustained remission.
This raises an important point, unfilled knowledge gaps in hand surgery. Need for more evidence-based practice.
A critical area. Despite advancements, continued pressing need for high-quality, evidence-based studies in hand surgery. Crucial for rigorously evaluating efficacy, long-term outcomes of techniques, especially comparing newer, often more expensive interventions. Need to ensure they're truly superior, scientifically evaluated, not just anecdotally. This gap means some widely performed procedures lack the robust comparative data we'd ideally have.
So, bridging this gap, confirming conservative efficacy versus need for rigor and surgical validation.
Efficacy of conservative treatment, multimodal approach with mobilization, orthosis, meds, is well confirmed for short, medium-term relief in early primary arthritis. Robust initial pathway, always explore thoroughly. However, while some surgery like trapeziectomy for advanced CMC1 arthritis is proven reliable, many other hand surgery interventions still need verification under controlled, evidence-based steady conditions. Addressing this knowledge gap is paramount for future advancements, ensuring most effective, evidence-backed treatments. Means investing in robust clinical trials to validate surgical practices, continuously improving outcomes based on solid data.
Professor, this has been an incredibly insightful deep dive. Your expertise and guidance have been invaluable. Thank you for walking us through such a comprehensive and nuanced discussion.
It's been my genuine pleasure. I truly hope this discussion equips our colleagues with valuable, actionable insights for their daily clinical practice.
So what does this all mean for you, our dedicated listener? We've explored the diverse types, delved into diagnosis, uncovered the full spectrum of treatments. The key takeaway: the undeniable importance of a patient-centered, evidence-based approach. We encourage you to integrate these insights into your practice. Always consider individual needs, functional aspirations, latest evidence to tailor plans for best possible outcomes. If you found this deep dive valuable, please take a moment to rate and share Deep Dive Ortho with your colleagues. It helps us reach more dedicated professionals like you. We truly appreciate your support. As we conclude, consider this. The intricate functionality of the human hand defines so much of our interaction, our independence. The ongoing challenge, the profound opportunity in orthopedics, is not just treating disease, but truly restoring that intricate functionality, enabling patients to live their fullest, most independent lives. Thank you again, Professor Moyamam.
Thank you.
This has been Deep Dive Ortho.